Okay, hello. Today we will be discussing about the antibiotic, the first part of this lecture. The antibiotic topic, how to choose. The main aim of this lecture is to make you understand how to choose an antibiotic in different infections in pediatric age group. So this discussion we have to discuss into four parts. The first one is an introduction to the different type of antibiotics and introduction to the bacteria. The second part consists of how to choose antibiotics in infections above diaphragm and how to choose antibiotic in a case of infection below diaphragm, and the fourth lecture is about sepsis. So, today we will going to discuss about only the part 1. The following sessions I will be uploading soon. So, the first topic we have to know is what all are the common bacteria which affect the pediatric age group at different organs. So, the first one is the gram positive cocci. The gram positive cocci consists of Staphylococcus and Streptococcus, and this Streptococcus will be our two types, mainly Streptococcus pneumoniae, Streptococcus pyogenes, viridans, etc., of which it will be causing pneumonia, sinusitis, tonsillitis, pharynx. Then Staphylococcus will be skin and soft tissue, bone, pneumonias, especially the complicated pneumonias, ventilator associated pneumonia, etc., can be caused by Staphylococcus. So, the next one we will be seeing the second group of organisms are gram negative organisms. The main gram negative organisms are Klebsiella, Proteus, E. coli, Salmonella, Shigella and Haemophilus influenza. These all are gram negative infection, and these gram negative infections have a contribution to majority of the infections in our pediatric age group, like diarrhea, pneumonia, UTI, any other abdominal infections, typhoid, as well as in pneumonias also, pneumonia, Klebsiella, Haemophilus influenza, all are contributing to pneumonias, which means the take home message from this slide is gram negative organisms we have to keep in mind, because majority of the infections are a contributor of gram negative, and in sepsis also we have to think of gram negative coverage. So, what we understood from here, whenever we choose an antibiotic, it should have some gram negative coverage. Only few exceptions are present for this, like in case of upper respiratory tract infection, it is mainly caused by Streptococcus. So, there, even though the antibiotic what we choosing, if not have an gram negative coverage, it won't be cause much harm, but all the majority of the other infection, gram negative coverage for the antibiotic that we choosing for that is a must. So, that please keep that in mind. So, now let us third group is our other groups like atypical bacteria, Rickettsia and spirochetes. So, today we will be discussing mainly on these groups or the antibiotic for these groups. Okay. So, now we will be rushing through the different group of antibiotics, which the knowledge understanding regarding each group is necessary to understand the how proper antibiotics in the different organs. So, the first group and the most common group is beta lactams, which consists of penicillins, cephalosporins and carbapenems. So, penicillins, the first found penicillin is natural penicillin, that is penicillin G, which is mainly toward the gram positive, because these penicillins are act on the outer layer of the cell wall of the organisms, So they were mainly toward gram positive, but in the semi synthetic penicillins there is one group called extended spectrum penicillin that is acting toward both gram positive and gram negative coverage. They have both the gram positive and gram negative coverage. What are the examples of extended spectrum penicillins? Aminopenicillin, uridopenicillin, carboxypenicillin, of which we have to know about ampicillin, amoxicillin, piperacillin, because these three are we commonly use in our pediatric practice. So that is extended spectrum penicillins. Now this penicillin, after the introduction of these penicillins, the bacteria start producing some enzymes. They start producing some enzymes to inactivate the beta lactams, and such beta lactams exclusively inactivate the naturally occurring penicillin, that is penicillin G, and the antibiotic which is highly related to, structurally related to penicillin G, which means such many bacteria start producing an enzyme called beta lactams. Some of such beta lactams was exclusively inactivating penicillin G and related penicillins, and that beta lactams are called penicillinase, and the other type of beta lactams are called the first generation beta lactams. They will activate other group also, like cephalosporins. They can activate cephalosporins, they can activate the other synthetic semi-synthetic penicillins like amoxicillin. So what we done to overcome this? Before that, this penicillinase is mainly produced by Staphylococcus, and the peculiarity is that majority of group of Staphylococcus, majority of the staph is producing what? Penicillinase. So we found an antibiotic which is resistant to this penicillinase, which means this penicillinase cannot be inactivate that new group, and that new group consists of methicillin and cloxacillin. So they classified as penicillinase resistant penicillin. So methicillin and cloxacillin. I told penicillinase is mainly produced by Staphylococcus. So methicillin and cloxacillin will be an antibiotic which act toward Staphylococcus. So please keep this point in your mind, because Staphylococcus is a notorious. So we have to be thorough with the bacteria which particularly acting against Staphylococcus. This is a first group. We have two more other group which will be acting toward the Staphylococcus. So that we have to complete our list by adding one by one. So first group you got methicillin and cloxacillin. This much clear? Now the other one, the other beta lactams, that is the first generation beta lactams. To overcome them, what we introduced? We introduced beta to overcome the beta lactamase, what we introduced? We introduced the chemicals which inhibit the beta lactamase, like clavulanic acid, tazobactam. They are called beta lactam inhibitors. So this is the way how we overcome the resistance produced by these bacteria. And one more thing before going to next slide, this type of beta lactams are mainly produced by the gram negative. So gram negatives are notorious for producing this type of beta lactamase. Now Now we will be going to the next thing, that is we will be now discussing the each group like ambi, amox and piperacillin. We have to know about these things. Ampicillin can act against both gram negative as well as the active against gram positive. So as I told, the ampicillin, amoxicillin all are comes under the group extended spectrum. So they can act against negative and positive. They are not active against Klebsiella pseudomonas. Even though they are negative, this Klebsiella and pseudomonas cannot be attacked by ampicillin, but they can active against the other gram negative like Haemophilus, E. coli, Proteus, Shigella, Salmonella, Helicobacter. Now amoxicillin same as ampicillin, the same coverage, but less active against Haemophilus influenza when comparing to ampicillin, and the other peculiarity is amoxicillin is highly orally available, orally absorbable, and amoxicillin is tedious, but ampicillin is 6th hourly. This much clear? This much clear? Okay. So now you tell one thing. If we give amoxicillin, so amoxicillin can act against gram negative and gram positive, gram negative and gram positive, but I told majority of the gram negative will be producing beta lactamase. So in short amoxicillin became an antibiotic against gram positive. Why? Because beta lactams are produced by gram negative. So in short, what in the present era, amoxicillin will be acting against only, mainly, not only but mainly toward gram positive. So to make the amoxicillin as a broad spectrum like gram positive and gram negative, what we have to do? We have to do the thing which inhibit this beta lactamase. So what it will be? Amoxiclav. So now in the present era of resistance, amoxiclav will be acting against positive and negative, while amoxicillin we cannot much rely amoxicillin for protection toward gram negative. This much clear? That is the mechanism, that is the importance of beta lactamase to be added in amoxicillin. So now that the details or how it will be help in the clinical practice, that I will explain in the coming sessions. So the next penicillin group is piperacillin. This is very commonly used as a combination with the tazobactam known as Pipzo. So it will be acting against Klebsiella, Pseudomonas, majority of the Enterobacteriaceae, which means gram negative, bacteria and anaerobes. So the Pipzo main coverage is gram negative, number 1, anaerobes number 2. So do you notice one thing? This is a gram negative antibiotic. Pipzo is a gram negative. Please keep in mind, it will be used. We will be revising this session in the topic pneumonia again in the coming lectures. So Pipzo is a antibiotic which is used for gram negative coverage, mainly gram negative coverage. So this is the line from our Tripathi textbook, serious gram negative infections. Okay, this much clear. Now next, second beta lactam, cephalosporins. Cephalosporins, what we have to understood, the first generation cephalosporins are cefalexin and cefazolin. They have gram negative and positive. Cefazolin we usually not use in our pediatric age group commonly. They are mainly used as a pre-surgical prophylaxis. pre-surgical prophylaxis in surgery and gynae patients. We have one thing important in first generation is cephalexin. They are active against penicillinase producing organism, and I would like you to remember rewind what I teach you previously. What is the common organism producing penicillinase? Staphylococcus. Just to see here, penicillinase is produced by majority of the Staphylococcus, and this first generation cephalosporin, what we called as a cephalexin, is the another drug for Staphylococcus. So now you got the second drug for Staphylococcus, that is cephalexin. So cephalexin is the second drug you got for staph. This much clear. Now we are going to second generation cephalosporins, that is first one is cefuroxime. Cefuroxime is active highly against gram negative and especially beta lactamase producing organism, which means the gram negative organism have a tendency to produce beta lactamase, but that beta lactamase not able to inactivate cefuroxime, which means cefuroxime will act against the gram negative organism even though they produce beta lactamase. This much clear. So gram negative, and they can kill even they produce beta lactamase, and the other group is some anaerobes and some gram negative cocci also. So if this cefuroxime can kill the majority of the gram negative organism, we can use, because cefuroxime is an oral drug, so we can use cefuroxime as a drug during discharge in a patient who was on other like ceftriaxone or any other high antibiotic which was used to cover gram positive and gram negative, and if we want to continue this gram negative gram positive coverage even after discharge, we can select cefuroxime. This much clear, because it contains both gram positive and gram negative coverage. Then come to the third generation most commonly used antibiotic group, that is taxim and ceftriaxone. Cefotaxime and ceftriaxone, the most commonly used group, third generation. This much clear. They are highly active against gram negative Enterobacteriaceae, which means they are active against gram negative organism. What all are the Enterobacteria? Same thing what I explained, like Klebsiella, Salmonella, Shigella, Proteus. See, Klebsiella, so active against pneumonia, Proteus, urinary tract infection, Salmonella, enteric fever, Shigella, dysentery. So which means they are active against majority of the infection, especially majority of the gram negative Enterobacteriaceae, gram negative infections, and they have some action on cocci also, less active, but some action is there. And I told you, just again I am rewinding this this portion that I told you. In pediatric age group, gram negative is the main organism which causing disease. So an antibiotic which can cover majority of the gram negative will be a good antibiotic, which or a broad spectrum antibiotic. That's why ceftriaxone is a broad spectrum antibiotic, because ceftriaxone or the third generation can cover highly active against gram negative and also even though they are less but active against the gram positive cocci also. So which means gram positive and gram negative means they cover majority of the pediatric infections, because I told you pediatric infections are mainly because of this gram negative positive cocci and mainly by the this gram negative organism. Hence after third generation can cover both this. So third generation cephalosporins, the examples are cefotaxime and ceftriaxone. They do not have much difference. Both are used against gram negative and as a gram negative and gram positive coverage. But this cefotaxime and cefotaxime and ceftriaxone usually we are preferred as a second line, that we will be discussing when we discuss each topic like pneumonia, abdominal infections. At that time we will be discussing they are all the second or first line, whether they are first line, whether they are second line, that we will be discussing in each of the discussions. And another third generation cephalosporin is ceftazidime. They are mainly acting in pseudomonas, because here we told cefotaxime is not active against some organism like Staph aureus and pseudomonas, and ceftriaxone also not active against Staph aureus. So third generation will be active against all the infection except staph. Keep in this mind, please keep this in mind, except staph they are active against majority of the bacteria. Now the third group is carbapenems, and the example is meropenem. They are active against gram positive cocci, Enterobacteriaceae, Pseudomonas. Enterobacteriaceae means all the majority of the gram negative organism what we cause the disease, what we explained previously. Then Pseudomonas, Listeria, anaerobes, which means gram positive, gram negative, anaerobes, beta lactamase produced by the beta lactamase producing bacteria. So which means they will cover all the group except MRSA. So hospital acquired staphylococcus we cannot rely on meropenem. This much clear? This much clear? So meropenem will be covering all except MRSA, which means staph. So if you are giving meropenem, we should be supplied with another drug which will able to cover staphylococcus in a case of serious or sick child, or in a case of sepsis when we are not sure about the staph or the other organism. So we have to cover meropenem along with another anti-staph medication that we will be discussing soon. So this much clear? Then tetracycline I will be just touching about. The hero is doxycycline. They are active against spirochetes and rickettsia. So now we are coming back to our the first slide, that is the bacteriology. So now you tell, we will be discussing each one by one with your previous knowledge. We will be discussing Streptococcus, amoxicillin, that is the simple penicillin is enough, because Streptococcus is not commonly producing what beta lactamase. So amoxicillin is enough. Staphylococcus, the two we already discussed is methicillin and the first generation cephalosporins. Which one? The first generation cephalosporin, the oral drug, that is the drug against the second drug against this one, which one? Cephalexin. So cephalexin is the second drug for staphylococcus. So staphylococcus, second drug is cephalexin. Spelling is not correct, cephalexin. Then all the gram negative coverage amoxiclav. Why? Amoxicillin alone will be act as a positive, because all the gram negative are producing beta lactamase. So, we have to add beta lactamase inhibitor. So, another gram negative coverage, third generation cephalosporins. Third generation cephalosporins are good for covering gram negative, and second generation cephalosporin also, which one? Cefuroxime. So, this much clear. Now, atypical now I told that is now. So, we reached the atypical organism. So, atypical which is caused by whom? Atypical which is covered by doxycycline, that is Spirochetes, Rickettsia, Mycoplasma, Actinomyces. Sorry, not atypical, the other groups, the Spirochetes, Rickettsia and the atypical bacteria like Mycoplasma, Actinomyces, but they are moderately active, moderate action only, but Spirochetes and Rickettsia are highly susceptible to sensitive to doxycycline. So, now we will be discussing one thing regarding doxycycline. Doxycycline should not be given along with the milk, iron preparation, non-systemic antacids and sucralfates. These will be reducing the absorption. And doxycycline we can give as OD or BD, that is our choice. If we are able to give OD then or BD, we can choose either of this regime. And next thing regarding doxycycline is that I told and I discussed in our group regarding the age group of doxycycline. Here see, this is an AP, American Academy of Pediatric notes regarding doxycycline age group in 2020 they published, in which they are mentioning CDC recommendation. What they are telling, doxycycline as the treatment of choice for children of all age group with suspected tick-borne rickettsial disease. Nothing that previous concern about the tooth staining in children less than 8 years stem from older tetracycline class drugs that bind, which means now they are telling we can use in less than 8 year also. And one more evidence, this is from CDC, another second evidence from CDC publication. They are telling now if the child is having, if we are sure about the rickettsial disease, and we can use even though with child is less than 8 years. And the other from the lecture of IAP infectious disease, they are given the references for safety of doxycycline in less than 8 years. So, this much clear, which means less than 8 year also we can use. This much clear. Now, we will go into aminoglycosides. Two drugs we have to remember, amikacin and gentamicin. Aminoglycoside we have to see when we will be using. As you know, aminoglycosin is active against gram negative aerobes, but this will be used only in case of serious infections like newborn, because newborn each infection we have to consider as serious. So, that is why we have to use amikacin in newborn infections like ICU care, any sepsis, or when we suspecting a gram negative sepsis in an ICU care patient, post operative serious infections in newborns, or we will be using for a gram negative coverage, we will be adding amikacin, and they usually given along with other drugs like penicillin and cephalosporin. Why? Because this penicillin, cephalosporins are act on the cell wall, but aminoglycosides act on the 30s subunit of the 50s subunit, this protein complex, 50 and 30s protein complex, that means they act in the intracellularly. So when this penicillin and cephalosporin, beta lactams act on the cell wall will not be formed properly. So our aminoglycosides can go inside and act on this target properly. So if we add this group and this group, the action will be increasing. Understood? The action of aminoglycoside will be high. Why? Because this group of antibiotics will facilitate the entry of aminoglycosides. So that's why majority of the time aminoglycoside is given along with other drugs to get at synergistic actions, when they will be giving only in a serious conditions and in Pseudomonas, Proteus and Klebsiella conditions, like burn patients. Proteus, severe UTI and UTI related sepsis. Klebsiella, when the pneumonia is very severe and not responding to others, we can think of adding amikacin, because that time it may be because of Klebsiella. So this much clear. Now we have two options, Genda and amikacin. Which will be choosing, or which is the best option? Actually in Tripathi, our pharmacology textbooks, they are telling what they are advising. They are advising that amikacin is a reserved drug which is used when we think that gentamicin is resistant, or the bacteria is resistant to gentamicin, or when the baby having an hospital acquired infections. So they are preferred to give gentamicin first, amikacin only if we suspect gentamicin resistance or it is a hospital acquired infections. This much clear? Okay. Now the main two problem with this group of antibiotics is ototoxicity and renal damage. The peculiarity of ototoxicity is that concentration dependence, which means when it cross a particular concentration, suppose when it cross a particular concentration only, it will cause ototoxic effect, but the renal damage is total dose dependent damage, which means the total how much dose the child get in during a course. So that will decide the renal damage, whereas ototoxicity is mainly concentration at each point of time, which means you take a morning dose, you take an evening dose, in between that how much concentration is there, that will decide ototoxicity. Okay. Now ototoxicity is non-reversible, but renal damage is reversible when we stop the drug. Another thing, once renal damage happens, this aminoglycoside won't release outside. So it will pile up in the body and it will increases the concentration. Once the concentration increases, it will lead to ototoxicity. So that is the problem. And renal damage is happen only when we use in a pre-existing kidney injury patients, and when we use along with other renal toxic drugs like NSAIDs and vancomycins. This much clear? So this is one study which is telling that to reduce this toxicity by aminoglycosides, what we have to do, we can give as a single dose of OD dose. If we give an OD dose, they are telling, this study is telling the toxic effect of aminoglycosides can be reduced. So now let's see the macrolides. The best classical example is azithromycin. They are act against the atypical bacteria like mycoplasma, chlamydia, legionella, campylobacter. This azithromycin is more active against Haemophilus influenza also. Along with that, some gram positive cocci also, which means they can act against the gram positive cocci as well as atypical bacteria, but they cannot cover the gram negative. So, when we are suspecting a atypical etiology or gram positive etiology, that means usually more than 5-year pneumonias, then we can select azithromycin. This much clear? Then last one is glycopeptide. Best example is vancomycin. Vancomycin, what is the coverage? First and the most important is MRSA. MRSA. This much clear? Then Clostridium difficile. What it causes? It will be leading to the disease called antibiotic associated enterocolitis. That is pseudomembranous colitis is caused by Clostridium difficile. In that case, we will be using vancomycin. Then vancomycin have ototoxicity. Vancomycin have a bactericidal action. They will kill and degrade the bacteria. So now, from the discussion up to this, now you see Staphylococcus, majority of them will produce penicillinase. So we have to give either of this, because methicillin can overcome the penicillinase. In the amoxiclav, this clav can overcome the penicillinase. Cephalexin is a third generation cephalosporin which can also have an action against penicillinase also. So when we suspect a staphylococcal infection with the penicillinase production, we can choose methicillin, amoxicillin, cephalexin. How we will produce, when they will see, like what? Simple pneumonia, skin infections, simple skin infections. So in skin infection we will give orally cephalexin. Simple pneumonia we will be giving what? Amoxiclav. But when the staphylococcus attain a resistance against methicillin also, they are called MRSA, and this type of staphylococcus is produced in a hospital setting. So hospital acquired infection or a complicated staphylococcal pneumonia, we have to think of vancomycin. Why? Because vancomycin is acting against MRSA. So now you know how to treat a staphylococcal infection. First we will give either of this depending upon. By simple pneumonia we will give only amoxiclav. In a simple skin infection we will give cephalexin. So amoxiclav will cover gram negative, gram positive, which all are the etiological agent for a pneumonia. So in our pneumonia, amoxiclav is needed. But skin infection is mainly by staph only, and cephalexin mainly have only staphylococcal coverage. So skin infection we can choose cephalexin instead of amoxiclav. Why? Because amoxiclav we are giving unnecessary gram negative and gram positive coverage by a drug which is covering both. But we need only staphylococcal coverage in a skin infection. So skin infection, oral drug cephalexin, and if it became MRSA, vanco. This much clear? Acha. Then next last group is this one, that is our linezolid group. They are active against MRSA like vancomycin. If they became vancomycin also vancomycin resistant Staphylococcus aureus, then our drug is linezolid. So vancomycin resistant Staphylococcus aureus. This much clear? Then all the penicillinase resistant streptococcus also. So that you leave. Now you think of this one, MRSA and VRSA. So they usually use in a sick or non-sick skin and soft tissue infections, like and other second hospital acquired pneumonia, sepsis. But all these are used very restricted manner, because linezolid is a drug of TB, used in multi-drug resistant TB. So that's why should not misuse linezolid unnecessarily. Should not use linezolid unnecessarily, because it's a drug reserved for TB management. If we start using linezolid like any other drugs, then again that bacteria will again resistant against linezolid also. So in a limited setting only linezolid we are using linezolid. One of such limited use is when we are want to make vancomycin to oral, then linezolid is the choice, because linezolid is available in oral dosage also. So the child was on vancomycin for severe pneumonia or severe lung abscess with suspected MRSA. So when during discharge we will be changing to linezolid. So this much clear. So now we will be moving to another last two topics from this session. So now we know about two type of beta lactamase. That is, what is that? We will be going back to that. What is that? Like here. Okay. So see this. Sorry, this one. Bacteria will be producing penicillinase, that is very short acting or very narrow spectrum beta lactamase. The other one is little bit broad spectral beta lactamase, that is called first generations, which will be inactivating some cephalosporin, some other penicillins, etc. Not only this, there are so many other beta lactamase. So now we are going to discuss about beta lactamase, which means the enzyme produced by the bacteria to neutralize the beta lactam antibiotics. So first two beta lactams you understood. Streptococcus usually not producing much. First generation beta lactamase is mainly produced by E. coli, Haemophilus influenza or Staphylococcus. So how we will overcome them? Amoxiclav, because this clavulanic acid can inactivate it, or cephalosporins. Cephalosporins can act against gram negative organism even though they produce beta lactamase. This much clear? But next, this is the problem. Some bacteria, after producing beta lactamase, they will start producing, when we give this antibiotics, they will start producing extended spectrum beta lactamase, which means amoxiclav and cephalosporins also will not be effective. At that time, what we will do? We have to add pibzo. So pibzo is act against gram negative even though they produce extended spectrum beta lactamase. So after giving pibzo, some will start producing AMPC beta lactamase, which means AMPC beta lactamase, they will be inactivating the cephalosporins, pibzo also. So in that case we have to give meropenem. Sometime meropenem is a carbapenem. Sometime the bacteria will start producing carbapenemase also. At that time we will give cholesterol. So now you see, this is the order you choose an antibiotics, and now I hope you know or you understood why this is the order of choosing antibiotics. So see, meropenem can act against bacteria even they produce AMPC beta lactamase, extended spectrum beta lactamase, so first generation beta lactamase. That's why meropenem is more superior to Pibzo. That's why Pibzo is more superior to because Pibzo can act against extended also. That's why Pibzo is more superior to amoxiclav and cephalosporins in acting against a gram negative organism which producing ESBL also. So that's why this is the order of antibiotic which with respect to acting against a especially gram negative or any other bacteria which producing beta lactamase. This much clear. That's why that's how it became the proper order of ascending order of antibiotics. But which doesn't mean that in all infection this is the order. In all separate, each infection their own protocol is separate infection, they have their own protocols that we will discuss in the coming session, but in general this is the order. This much clear? This much clear? And so from the discussion up to this, we will be having some question answer section, like suppose ceftriaxone and meropenem, whether this combination is a rational combination or not. Tell. See, meropenem, here dekho, meropenem can act see, 1 second, meropenem will act against gram positive, gram negative, extended spectrum beta lactamase producing bacteria, AMPC spectrum beta lactamase producing bacteria. Ceftriaxone can act against gram positive, gram negative beta lactamase producing only, which means both are having gram positive, gram negative coverage, beta lactamase producing coverage by ceftriaxone, but meropenem having all the others also. So this is not a good combination, which means ceftriaxone is waste here, because all the coverage is already giving by meropenem. So ceftriaxone meropenem is not a good combination. Now Pibzo mero. Pibzo mainly acting against gram negative, meropenem having all gram positive, gram negative, anaerobes, extended spectrum beta lactamase, AMPC lactamase. See, it have AMPC also, but Pibzo don't have that one, which means Pibzo and mero having the equal coverage. Along with that, mero have some extra also. So Pibzo is wasting here. So this is not a good combination. Mero Pibzo no need to combine in any protocols. Next one, Pibzo and Metrogel, metronidazole. Pibzo having anaerobic coverage, Pibzo having gram negative coverage. Metronidazole is for anaerobic coverage. So whether any need to add Metrogel during Pibzo? No need to add Metrogel in case of appendix and other abdominal infection if you are giving Pibzo. This much clear? This is a general point, but from disease to disease there may be variation in the protocol. So during that time you stick to each protocol that we will discuss in the coming class, but now I am telling the general rule regarding antibiotics. So this also just we will wipe out. This much clear? Piptase and aminoglycosides. Yes, we can add, especially they are used in case of a blood cancer, which means blood malignancies with neutropenia, which means febrile neutropenia. In that case, they are advising. Otherwise, it's no need, both have gram negative coverage, but if you add, the action of aminoglycoside will be increasing, because piptase will act on cell wall, so aminoglycosides can enter into the inside the cell, but better to avoid, because it will increase the nephrotoxicity of aminoglycosides. Okay. Now ambigenda, ceftriaxone genda, this one is penicillin group, act on cell wall. This one is cephalosporin, again act on cell wall. So both will be acting on cell wall. This aminoglycoside can enter into the cell easily. So these two are a good combination, because gentamicin will having a good action if we give a cell wall destroying antibiotic. So that's why this combination we are using when there is a serious, when we are suspecting a serious gram negative, example neonate. That is the reason why gentamicin ambi or ceftriaxone gentamicin we are including in a in a neonatal infection. So this much clear. So this is the basics of antibiotics. Now we will be dealing in the next session. We will be discussing about the infection above diaphragm. Then in the successive sessions we will be completing the infection below diaphragm and gram negative sepsis, how to manage sepsis.